friends, hope all are fine and healthy. Welcome to SS Virtual Medicos. This is Sandro Matthew here. Today we will continue our discussion with the peptic ulcer treatment. We will go through the introduction, then the normal physiology, and finally the classification of drugs. Let me give you a brief introduction. As said in the previous video, the peptic ulcer is the lesion in the lining of the stomach and duodenum. Okay. How these lesions occurs in the mucosa of GIT? This mainly happens due to the imbalance between aggressive and the defensive factors leading to the tissue damage. Let's see what are those aggressive factors. HCl, H.PYLORI, Gastrin, bile acids, smoking. These are some of the aggressive factors. Let's discuss what are the defensive factors. Bicarbonate, mucous membrane, prostaglandin, MUCOSAL, blood flow. These are the main defensive factors or the protective factors. Okay. In normal condition, a balance is there between the gastric acid secretion and the mucosal defense. If the aggressive factors increases or the defensive factor decreases, this can lead to epithelial injury. That means it causes peptic ulcer. Now I would like to brush up your physiology in regulation of acid release. As you know, parietal cells, also known as oxyntic cells, they are found in the fundus. They are found in the fundus and body of stomach. And what does it secrete? It secretes HCl and intrinsic factor. What GCELLs produce? It secretes gastrin, and where it is mainly found? It is found in the pylori gland of ANTRUM. It is found in the ANTRUM. What it secretes? Gastrin. It is a peptide hormone. Remember that. Before going into details, I would like to make sure that you should remember this table. Muscarinic receptor, histamine receptor, cholecystokinin receptor, when stimulated, it increases the HCl production in the stomach. On the other hand, when the prostaglandin receptor, for example PGE2 receptor or the EP3 receptors are stimulated, this will decrease the HCl in the stomach. So now let's see what actually happens in stomach. Consider this as lumen of the stomach. This is the parietal cells, this is the surface epithelial cell, and this is the ECL, that is enterochromaffin like cells. This is the G cells. Okay. So these parietal cells are having M3 receptors, EP3 receptors, H2 receptors, CCK receptors. Okay. So let's see actually what happens and how the HCl is secreted. The enterochromaffin like cells secretes the histamine, and this histamine will be binding to the histamine receptors present in the parietal cells, leading to the HCl secretion. Let's see what G cells do. G cells produces the gastrin, and this gastrin binds to the E cells, that is enterochromaffin like cells, and increases the histamine bind to H2 receptor, and this lead to increased HCl production. Also gastrin can bind directly to the parietal cell and increase the HCl production. See this vagus nerve. Vagus nerve will be secreting the acetylcholine, and this acetylcholine can stimulate the M3 receptors present in the parietal cells, right? M3 receptors present in the parietal cells is stimulated by the acetylcholine. Also, the M1 receptors present in the enterochromaffin cells. And finally, this stimulation lead to the HCl production. So one more receptor is pending, that is EP3 receptor or the prostaglandin receptor. When prostaglandin receptors are stimulated, this leads to decrease in HCl. Remember that all the other receptors like M3 receptor, H2 receptor and CCK receptor increase the HCl production, while PGE2 receptor or the EP3 receptor decrease the HCl production. Hope that's clear. Also, I remind you that there is a cell near the parietal cell, that is surface epithelial cell, or it is known as the MUCOSAL. It secretes the mucus and the bicarbonate when stimulated by the prostaglandin on EP3 receptor. Okay. So, I hope you understood how this HCl is secreted and how this mucus and bicarbonate is secreted. So, let's see what actually happens inside the parietal cells. The M3 receptors and the CCK receptors are G coupled, that means the GQ coupled receptors. So, hydrogen potassium pump will be activated by the calcium dependent pathway. Through this calcium dependent pathway, it activates protein kinase, and this protein kinase finally act on the hydrogen potassium ATPase or the proton pump, and hydrogen is secreted into the lumen. Okay. So, let's talk about H2 receptors and EP3 receptors. H2 and EP3 receptors are CAMP dependent. Those are CAMP dependent pathway. And the difference is, when EP3 receptors are stimulated, it inhibits the phosphokinase, so the hydrogen ion secretion will be also decreased. And in case of H2 receptor stimulation, when the CAMP dependent pathway is activated, leading to activation of protein kinase, finally HCl or the H plus ions are secreted into the lumen. This is what happens inside the parietal cells. Okay, so we understood how the H plus ions are secreted into the lumen. Let's see how the chlorine ion is secreted into the lumen. There is a co-transport, that is chlorine potassium co-transport. So through this pump, the chlorine is secreted and the hydrogen ion and chlorine combine to form the HCl. This is how the HCl produced in the stomach. So this is how HCl, mucus and bicarbonate produced in the stomach. Normally, as we said, there is a physiological balance, and in case of ulcer, the aggressive factors increases or the defensive factors decreases. So I hope you are clear with this. If you are understanding this mechanism, it will be easy for you to understand the pharmacological action of each drugs. So now let's see what are the classification of drugs. We have four main classification: anti-secretory drugs, antacids, mucosal protective drugs and H.PYLORI drugs. Anti-secretory drugs means it directly decreases the HCl production. From the name itself, we can understand the action of those drugs. H2 receptor antagonist. Okay, if we are blocking the H2 receptor, what happens? HCl production will be decreased. Proton pump inhibitors. That means the hydrogen potassium pump. If the hydrogen potassium pump is inhibited, then also HCl is decreased. Anticholinergic drugs. if we are blocking the M3 or M1 receptors, this will also decreases the stimulus for HCl production. Prostaglandin receptor analogs, that means if prostaglandin or the analogs are given to the patient, that can stimulate the EP3 or the PGE2 receptor, leading to decrease in HCl. So these are the anti-secretory agents decreasing the HCl. Alright, let's see what all drugs we can see in H2 receptor inhibitors. We have cimetidine, ranitidine and famotidine. So if you are seeing tidine in the end of those drugs, you can say this belongs to H2 receptor inhibitors. What actually in H2 receptor inhibitors do? It reversibly inhibit the H2 receptor. Okay, it reversibly inhibit the H2 receptor. Okay, and the most important thing which we need to remember about this H2 receptor inhibitors are these drugs inhibit the CYP450 enzyme, and it is most commonly seen with cimetidine. And least commonly seen in famotidine. Okay, hope you are clear with that. Okay, then we can say what are the uses of cimetidine, ranitidine and famotidine. This can be used to treat the peptic ulcer, stress induced gastritis, but mainly we use for treating the stress ulcers. Stress ulcers. Okay, let's see what are the side effects. These are usual side effects like headaches, myalgia, diarrhea, etc. The main thing which we need to remember about cimetidine is it is having extra side effects. That includes gynecomastia, increasing in breast size, impotence, mainly in men. Okay, this is seen with cimetidine. Also, you should remember that famotidine is the most potent among H2 receptor inhibitors. Let's move and see what proton pump inhibitors do. It irreversibly inhibits the hydrogen potassium ATPase. Irreversibly inhibit the hydrogen potassium ATPase. Prazole, omeprazole, pantoprazole, rabeprazole. While seeing prazole at the end of these drugs, you can say it belongs to PPA, that is proton pump inhibitors. Okay, and the main thing which you should remember is about the entry coat. Proton pump inhibitors have an entry coat which is acid resistant. This actually produces the systemic effect. That means the drug is actually covered with the entry coat which is acid resistant. So the absorption of PPA takes place in the intestine, and then it is delivered to the blood, and then from blood it comes to act on the parietal cells. Usually we use PPAs to treat Schollinger-Ellison syndrome, GERD and peptic ulcer. Alright. Long-term use of PPA lead to few side effects. That include decrease in calcium leading to osteoporosis, decrease in B12, vitamin B12 lead to megaloblastic anemia. Also, it increases the risk of infection. Next is anticholinergic drugs. It blocks the M1 receptor, not the M3 receptor. It blocks the M1 receptors present in the dendrochromaffin-like cells. It includes pyrancepine, telancepine. You can identify whether it is anticholinergic drug acting in the stomach when you see this cepine in the end of these drugs. Okay, the side effects are usual side effects like dry mouth, blurred vision, tachycardia, etc. The next is PGE2 analog, and we have misoprostol in that category. This will be stimulating the PGE2 receptor and decrease the HCl production. The main thing which we need to remember about misoprostol is it is contraindicated in pregnancy. Because it increases the uterine contraction leading to abortion. So now we can discuss about antacids. Actually, antacids act by neutralizing the HCl present in the stomach, and it is mainly used to get the fast pain relief. It gives fast pain relief. We have aluminum salts and magnesium salt. Aluminum salt is aluminum hydroxide and magnesium hydroxide. Aluminum hydroxide have a side effect. It is constipation. Magnesium hydroxide has side effect diarrhea. So usually aluminum hydroxide and magnesium hydroxide are combined together. Next we can see mucus protective agents. We have sucralfate, colloidal bismuth subcitrate. What actually sucralfate does is, okay, let's consider this as stomach. If you are having an ulcer over this area, sucralfate actually cover the ulcer. This will be protecting the ulcer. So since that ulcer is protected, it increases the angiogenesis leading to healing. Okay. Also remember that antacids are not given with sucralfate because antacids are given to reduce the acidic property in the stomach. Actually, the sucralfate will be working in the acidic pH, so they are not combined with antacids. Not given with antacid. Next is colloidal bismuth subcitrate. It is also having the same action of sucralfate, but the main thing which we need to remember about colloidal bismuth subcitrate is bismuth poisoning may lead to 3 B's, that is brain encephalopathy, bone osteodystrophy, black tongue. Okay, remember that. The last is H.PYLORI eradication. We have already discussed about this in the previous video. We have triple drug therapy regime and the quadruple drug therapy regime. Triple drug therapy includes clarithromycin, amoxicillin and pantoprazole. So for easy remembering, we can make a mnemonics called CAP. So the CAP drugs belongs to triple drug therapy: clarithromycin, amoxicillin and pantoprazole, or any other kind of PPA. Quadruple drug therapy, it includes bismuth, tetracycline, metronidazole and pantoprazole. Now let's recap and see what all things we have learned today. The aggressive factors and the defensive factors, what parietal cells secretes and where it is found, what GCELL secretes and where it is found. Whatever you forget, remember this. If you are remembering this table or this box, it will be easy for you to remember the pharmacology. So after that we have learned how the HCl is secreted into the lumen. We have discussed about the classification of drugs, how it is acting on the receptors. Remember about the we have discussed about the potency regarding few drugs. Yeah. Also remember that omeprazole is the most potent among the PPA, that is proton pump inhibitors, omeprazole. Okay, so we have almost covered everything in peptic ulcer pharmacology. Okay, thank you for your attention. Bye until we see next time. Thank you.